Great. All right, let's get started. Thank you to the panelists. So today's session is about vulnerable communities. It's about payment models in Medicare and Medicaid and how the models that we have today may or may not leave behind some of those vulnerable communities. And that's all in the context of an incredible and kind of massive adoption of technology as well as consumerism in during the pandemic over the last 18 months or so. And so today we have a panel with very esteemed colleagues who will be who know this space very well and will be educating us to some of their own work and programs. And then we will go into a Q&A session after they've each had a moment, about 10 minutes apiece, to talk about what they're up to. My name's Timothy Peck. I'm an emergency physician by training. I'm also a serial entrepreneur in the elder care space and in medical technology, and have had a good amount of experience trying to push through programs through CMS and Medicare and through Congress, through the legislative process as well, to try to create real change in how we use technology and value-based care. So that's my background. But more importantly, our panelists today, we have Megan Douglas, who is Assistant Professor of Community Health and Preventative Medicine at Morehouse School of Medicine. And then we have Courtney Stevens. She's Director of Virtual Care at Henry Ford, and Dr. Marotra, who is a hospitalist at Beth Israel Deaconess and Assistant Professor of Healthcare Policy at Harvard Med School. So without further ado, I'm going to turn it over to Courtney to give us some remarks, tell us what she's been up to at Henry Ford, and a little bit about how she's seen reimbursement change during COVID and what that's meant for patients and vulnerable populations.
Awesome. Thank you so much, Tim, for that intro. So my name is Courtney Stevens. I just want to comment that I think this is a great and a timely topic as we balance offering these great services, helping bridge that digital divide, yet entering into a time of uncertainty for reimbursement for these services. Henry Ford Health System was established as a unique integrated health system model back in 1915. We're one of the fourth largest employers in Metro Detroit in Michigan, with that mission to improve human life through the excellence of science and the art of healthcare and healing, but really to transform lives and communities through health and wellness, one person at a time. So just looking at Henry Ford at a glance, we have 5 acute hospitals, 3 behavioral health hospitals, over 200 care sites, which includes 44 medical centers. And within our health system organization, we have the Henry Ford Medical Group, which has about 1,600 employed physicians, as well as Health Alliance Plan, which is a health insurance arm that has about 600,000 value-based lives. And although we have about 3.7 million outpatient visits, we have as many as 3.2 million digital touches or encounters, including our patient portal, as well as various virtual care connections throughout that as well. Diving a little bit deeper into virtual care and telehealth at Henry Ford, knowing that 2020 was a pandemic year, we produced over 420,000 virtual encounters and consults last year, which was an astronomical growth from the 17,000 that we had in 2019. But with that 420,000 in virtual encounters, we saved patients over 3 million miles or travel saved, and almost 4,000 days of travel that those patients didn't have to take time off work, find childcare, find transportation where although we're a metropolitan in Detroit, we have many rural areas that encompass us. So it was great value. Touching on the reimbursement piece, we were lucky within our organization that we were a next generation ACO back in 2015, 2016. So we dipped our toe in the telehealth and virtual care reimbursement realm with that additional waiver and contract through Medicare for our Medicare beneficiaries. It gave us the chance to develop an infrastructure and a foundation of virtual capabilities that we could use telehealth for the care delivery once the pandemic hit. With COVID, it opened up adoption and sustainment of that foundation and tools that we had within our tool belt, but we continue to evolve and enhance those capabilities and options to really find that innovative way to incorporate virtual care within our care pathways across our care continuum. So it really turned from a do something to do more to now we're looking at let's do it right. Really find the right patient, right provider, right intervention, and figuring out where the reimbursement and the policies lead us to be reimbursed for those services that we're really trying to innovate on.
Awesome. Thank you for that opening, Courtney. Especially when we come back to doing some Q&A, I'd love to talk a little bit about value. You define value through and metrics for value. You talked about miles and days saved. I'm sure you have other ways of thinking about it, but would love to get into that conversation so that we can define that term. So I'll go to Ativ. So Ativ, you have a ton of research in this space and have a lot to say. Catherine, thank you for sharing the slides. Please take the floor.
Well, thanks so much, Tim. And Courtney, thanks for those comments. I'm going to pull out from Henry Ford all the way to a more national level. And, this is a really critical issue in terms of focus on how do we ensure that telehealth reaches all Americans, not just those with advantages. And I think before we turn to what has happened during the pandemic, I do want to pull back and remind ourselves, what was telehealth policy? Except for some exceptions, as Courtney mentioned with next-gen ACOs and so forth, the general policy, at least on the Medicare side, was that telehealth was limited to rural communities and also limited that a patient would have to be hosted at a clinical site to have their telehealth visit. While we might debate the use of that, telehealth was growing pretty rapidly in rural communities, though I think there was some sense that it wasn't growing fast enough. But from a purely equity perspective, that policy was very successful in the sense it was reaching the most disadvantaged. If we look at just people who live in a rural community who have mental illness, already a disadvantaged population, and then we look within that population, those who use telehealth were more likely to be disabled and live in a very low income community, highlighting that how telehealth prior to that pandemic with that relatively targeted strategy and the hosting of patients had reached a very disadvantaged population, and if anything, was narrowing disparities in the US healthcare system. If you go to the next slide, but we switched during the pandemic, and I think it's important to emphasize that we switched from providing telehealth within a clinical site to going to telehealth within a patient's home, either via video visit or via phone call, which is something I'll come back to in a moment. And obviously, the concern is that not everybody has access to either the technology or has the skill set to do a video visit. And that's been the term that has been, we've been using more and more, the digital divide. These are some data about Medicare beneficiaries, though I think it's applicable to the whole population, where the question was, what fraction of Medicare beneficiaries lack that necessary equipment? Again, a smartphone, a computer, broadband, all the stuff that's necessary for a video visit. On the right, it's broken down by income as a percentage of federal poverty line. And people who are poor are more likely not to have that technology. Those at less than 100% of the poverty line, 50% of them do not. And we see on the left, really important disparities in terms of race and ethnicity. And so this has led many, including those on the group, as well as myself and others, things to raise the concern that now that we flipped it during the pandemic, this digital divide was no longer going to be, telehealth was going to be widening disparities as opposed to narrowing disparities in the US healthcare system. Now, if you go to the next slide, life's always more complicated. And it's interesting to see what the data has shown so far. In some work that we published looking at telehealth use among people with private health insurance, a different population, I want to emphasize that, we found that telehealth use was more common among younger enrollees, people in the cities, but also surprisingly in lower income counties, as well as counties with more minorities. Not what I had expected there. Now, I should emphasize this is video visits and phone calls, another issue that we'll come back to. And on my last slide, I have just to highlight, we've seen kind of mixed data on this, with some finding that there's less use and some finding more use among disadvantaged minorities. One very consistent finding in the literature is that those in rural communities have less telehealth use. And that's particularly, at least I found, surprising, because I told you right at the beginning, prior to the pandemic, that's where all the use of telehealth was. So I thought because they had a head start, the technology was around, patients were more familiar, we'd see that in rural communities it would be used more, and that's been exactly the opposite. And so as we think about telehealth and the equity issues involved, and I'm hoping we come to on the panel, I guess I'd say a couple of things. Moving forward, first, there's a lot we don't know. One of a very important question is that, and an issue that comes up a lot in the debate is, should phone calls or audio-only telemedicine visits be covered? We don't know in the current data how well that, it's not well captured, so we don't know the relative role and how that's played out. And is that good if we use telephone care? I think there's the idea that telephone calls are the only way to reach certain populations, and I agree with that. But I also worry that if telephone calls are not as good as video calls, at least for some clinical issues, do we create a two-tiered healthcare system where the rich get video calls and the poor get phone calls? I also think that we all agree that this is a problem. Either way, we need to improve digital access and move it to all Americans. We see all our politicians, President Biden, the Congress, others talking about that issue. But I think what we really need moving forward is solutions, and specifically what works well. And lastly, a lot of the conversation, understandably, right now is about video visits. Makes sense. That's what most of our providers are using right now when we say telehealth. But there's a lot of other stuff, from portal messages to remote patient monitoring to e-visits, et cetera, that are, I think, as we move forward with telehealth, are going to play a larger and larger role in how Americans receive care. And we're going to have to be very careful about monitoring the issues of equity when we start thinking about these other models of telehealth. So a couple of ideas, and look forward to the Q&A.
Yeah, love that. Ativ, I would love to, when we get into the panel discussion, first of all, take a look at the chat. There's some questions around what are some of the other factors that, other than wealth, that might be restricting the use of telephone versus audio, audio versus video. And then also would love to really get into the conversation of what would need to be true to decrease some of this divide and make sure we don't get into a two-tiered system, and dig into that more. Great. So Megan, please, you have a lot to say about health equity, and you've done a lot of research here, and I'm pretty excited about you showing us these numbers visually, and also thinking about how policy can advance health equity. So
Yeah, absolutely. I'm so excited to be here and excited to have this conversation and share some of the work we've been doing recently. For those who may not be familiar with Morehouse School of Medicine, we are located in Atlanta, Georgia. We are one of 4 historically Black medical schools in the nation. And our mission is leading the creation and advancement of health equity. We focus on training the primary care workforce. And within Morehouse School of Medicine, I am affiliated with the National Center for Primary Care. We are the only congressionally designated primary care research institution in the country. And all of our work also focuses on health equity. We do a lot of training, technical assistance, and partnering with clinicians and practices that are, our focus is mostly on those that are serving underserved communities. So small practices, rural practices, those serving high proportions of Medicaid populations. We also do a lot of work directly with federally qualified health centers. We have a practice-based research network comprised of primary care associations and community health centers across 8 states in the Southeast. And that's what I will talk a little bit about some of the recent work that we've been doing that was really built on observations that we've made really over the last decade. And my boss, Dominic Mack, director of the National Center for Primary Care, is a family physician. He's been working in this technology space for much longer than that. And always reminds me that when we're having these conversations to really focus on the fact that the technology is a tool. And if the technology is not in the hands of clinicians who are serving underserved communities and patients in those communities, that the potential that we see with those tools is not being recognized and benefiting those patients. So we're coming at this, from that perspective, and had done some research in the earlier 2010, soon after the HITECH Act was passed, that we did see adoption disparities for electronic health records and use of telemedicine in the Medicaid program. And those EHR adoption disparities were really around clinicians who were in small practices, were serving in rural areas, and were serving large Medicaid populations. So in 2019, building off of some of that historical research, we launched the Digital Health Tools Study, which is a study that we're partnering with the United Health Foundation on. And our focus was on the 4 states highlighted here: Georgia, North Carolina, Kentucky, and Tennessee. We, like I said, launched this project in 2019. And then had grand plans of traveling throughout the Southeast and hearing directly from clinicians. And we had a big survey, and we're doing focus groups, and then COVID had other plans for us. We did incorporate some COVID specific questions into our survey, and that obviously became a huge topic of conversation in our focus groups. We were really concerned that we were going to have trouble, getting the attention of clinicians, and honestly didn't want to be getting the attention of clinicians when they were dealing with all things COVID related. And we're actually surprised at how much what we were talking about was resonating, because so many of the clinicians that we were trying to hear from were dealing with adopting and using digital health tools in their practice on a daily basis. So we ended up getting, the data that I'm sharing today is not our full study sample. At this point, we have over 1,200 surveys completed and conducted 7 focus groups across those states. And just want to highlight a few of the data points there. 90% of clinicians said they were using digital health tools because of COVID, and 54% said that it was their first time using telemedicine. And you'll see the state variation there highlighted, and not huge amounts of variation, but we are in the process of looking at some of the policies that were in place pre-COVID and some that were adopted during the pandemic to understand a little bit more some of the barriers and facilitators to adopting telemedicine during the pandemic. Next slide, please. And I actually think I'm going out of order a little bit here, but we did also, because of our relationships with federally qualified health centers, we had a very large proportion of clinicians serving in community health centers in our survey and in our focus groups. And I think the reimbursement changes due to COVID were pretty unique to community health centers, where there really was not a financially sustainable model for them to use telemedicine prior to COVID. So, I do think that we're seeing a lot of that pan out through the survey data. Was a little bit surprised with our satisfaction rates, especially with electronic health records. I still struggle to find spaces, especially talking with clinicians, where they have anything good to say about electronic health records. But I think now that we're really fully a decade in, at least from the incentives from the HITECH Act. So I think some of that satisfaction or dissatisfaction is starting to wear off a little bit for electronic health records. I think we're seeing a little bit of that with telemedicine, slightly lower satisfaction rate, but I still think higher than I expected to see. Next slide, please. And then I think really getting into the conversation today, I am an attorney by training. I am all policy. I live and breathe policy. I thought for sure reimbursement rates, reimbursement was going to be the #1 barrier from our survey participants. And I was absolutely proven wrong with that. Reimbursement was not the top 3 barrier or facilitator for adopting and using digital health tools. And I'll just be clear that this question was specific to, or was broadly about digital health tools, not specific to telemedicine. However, we did still see about 1/3 of our survey participants report that reimbursement by public payers was a supporting factor for their adoption of digital health tools. And I think where I would like to see this conversation today go is really that reimbursement is such a narrow conversation around what is needed to really support, especially primary care practices and practices that are serving underserved communities. We need to really be thinking beyond reimbursement and thinking about, how we reform financing primary care, especially in general. And I think that we see that a little bit with the role that the incentive payments played for electronic health records, and that of the 3 kind of payment-oriented answer options, that was the highest as far as the support goes. Really, I'm very interested. I think this is going to be a really great discussion. I think that we have some different points of views on the role of technology and equity, and some of our earlier findings in research. My perspective is that we had inequities in access, to telemedicine prior to COVID, and I think that we've seen some more movement towards equity because of the policies put into place. I don't necessarily have answers to where we go, but looking forward to hearing from the other panelists and discussing.
Awesome. Thank you, Megan. Those numbers are pretty interesting, a lot of fodder for a conversation right now. So let's start at the top with starting broad around what does value mean to you, especially in this area, especially as it relates to applying technology to disadvantaged populations. And let's focus on those populations because that's today's topic for sure. So Courtney, you talked about miles and days saved. Those are metrics that represent something very personal to the humans who have to find that time, have to find the money to go those miles, etc. And so wondering how you think about value within that or beyond.
Yeah, and it was interesting because recently we took a look at the Quadruple Aim and really what are some key bullets under those Quadruple Aim components that really drive home with virtual care and telehealth. So when you think of that quality and health outcome, virtual giving an opportunity for proactive care at the time that people need it most, maybe even increasing the touch points if needed, as you think about remote patient monitoring, asynchronous care, things like that. Improving that timely access to specialists. I mentioned how we have a metropolitan Detroit, but then we have a lot of rural or more extended areas. And many of those people in those outer reach areas have a hard time coming down to the heart of the city for some of those quaternary and tertiary specialists. So giving them the opportunity to extend that outside of the brick and mortar to really be able to extend to those patients. And in that case, some of them get diagnosed and treated earlier and can access or result in improved outcomes. As we think of affordability, using and promoting the sites of care shift to lower cost settings, focusing on patients that may default to urgent care or EDs, and giving them more accessible and on-demand virtual options that they can understand and have access to be able to maybe shift some of that higher cost area. And going back to remote patient monitoring, the home monitoring programs to really reduce some high cost hospital visits with the ability to keep them home and keep them healthy instead of having them have to revisit our inpatient settings. Customer experience, this is a lot of what you talked about with the miles saved, really easier access, simplifying navigation, and the ability to manage their own interactions. A lot of our patients are very interested in technology, and although we may have digital deserts, even within the city of Detroit, cell service is a barrier for some, but not for all. And it can still kind of give some of that access, but to the point that was made earlier, trying to find partners in our communities that can help bridge for those that don't. So we've talked about things like local libraries, or community centers or churches or things like that, where they may be able to go to some of those areas and resources that they trust to have some connectivity options to get the care that they need. But those may be more local and they may be more accessible to those patients so they can have a personalized mix of virtual and in-person to fit their lives. And then finally, the clinician experience. Really, this gives providers a new context to their patients. They are seeing them in their home. They're seeing them as a person, not just in the four walls of their exam room, which can really give a different ability of diagnosis and assessment for those providers sometimes. It's given some of our providers flexibility in work environment, which can help with some of the provider burnout. And really addressing some of those shortages and misdistribution of providers that we have within our region.
Interesting. And so a direct question is, is Henry Ford also doing some of these community outreach programs that you're talking about in the kind of wealthier, wider, more accessible neighborhoods as well? Or is this more a program that you're talking about of reaching people on the more disadvantaged populations?
It's both. So let me give an example. One of the programs we're working on is in a mobile integrated health program that maybe post-discharge, a patient is set up with a visit from a community paramedic or a Henry Ford paramedic that will actually go to their home and help facilitate a device-enabled video exam with them, with either their discharging physician or another physician of that service. And it supports those patients, they're coming right out of the hospital. We want to make sure they're staying home and healthy. Some of those being in the heart of the city of Detroit that may have transportation issues or technology barriers or Wi-Fi and broadband issues. But some of those may be in other areas where they might not have all those issues, but they don't have the digital literacy or the comfort, the telehealth literacy of using the tools. So having that community paramedic come in the home, help them use that technology, but then also be able to be on site and give them some support and services there as well is helpful. We've also established some what we call specialty centers in areas outstate Michigan where we don't maybe have brick and mortar facilities that can be a central location for people to come to more in their neighborhood, but there's staff there to support them in the technology connectivity And so they're not expected to do that with bring your own device or on their own network.
Got it. So Tiva, I want to go to you, but first I'm going to go to Megan. When we come back, I would really like to hear about this idea of a two-tiered system. You know, what's driving that, a little bit more about the audio versus visual and what the different value that those two different modalities bring, and why is that a divide? Megan, you talked about the payment models or the obstruction to payment not necessarily being a driver for adoption, a driver for sure, but not one of the top three drivers. It seemed to me that those drivers that were the top three were all around user experience, right? Ease of use, time, workflow integrations. And so, you know, how do we, that's traditionally, I'm a physician, it's a traditionally hard thing to get a company to give me a user experience that is up to snuff with a consumer product. How do we invest in that? What have you gone through that process of thinking there?
Yes, and also, you know, just reinforcing what we heard in our focus groups to back up the data there. We heard a lot from clinicians who were employed within their clinic or health system, so not didn't have ownership interest, and that was one of the biggest complaints that they had was, you know, my voice was not heard in the procurement process, or, you know, I didn't have a chance to actually inform any of the decision making about what kind of technology or digital tools we're using. And I think that plays into this in two ways. That one, incorporating those voices in those decisions gets to buy-in, you know, just on the kind of psychological side, but then also would be more conducive to a better user experience. And then on the other side of that, where we had like CMOs, chief medical officers, or, you know, some type of clinical leadership who was also seeing patients but did have a voice in the process, we heard ways that they were really leveraging resources that they already had and trying to streamline and make more efficient the workflow that they were already working with. And that made it a lot easier, especially in the midst of COVID, to be adopting things like telemedicine if there was already a program that integrated with their EHR, for example. So I think that's a huge, you know, from the organizational perspective, thinking about how clinicians and actual users and potentially and should be patients as well, you know, are incorporated into the decision making, especially to get the full value out of the, you know, financial investments that are being made. I also, you know, I'm glad that you picked up on kind of the differences. I think it's really fascinating, the differences between the barriers and the facilitators. The, you know, barriers really being focused more on that kind of administrative cost, time, workflow. Supporters workflow still fits in there, but really meeting patient need and improving patient health. So where we see those connections to what the patients actually need on as factors that supported adoption.
Yeah. My life as a physician entrepreneur, but as a designer, you know, completely believe in that, you know, this healthcare system that we're living in and made is kind of made for itself first and the user second. And if we focus on desirability and user experience, we can certainly drive value for everybody, including those who need to get paid, and as well as the patients, of course. So Atif, again, this two-tiered system, it's very provocative kind of way of talking about it. I love it. Actually, it really calls into focus what may or may not be happening. Would love to get your ideas of, you know, what is the value of audio versus video, and why are those two things of different value? And after we define that, then, you know, this divide is occurring. And what might we do? What might have to be true to smush it back together? Yeah.
Yeah. So before I jump into that specific question, I do want to emphasize some ideas here that when we think about equity, the issues that you just raised of user interfaces and design, I think are really important. It may not be something that people think about. I'll highlight a couple of ideas. When we talk to clinicians about why the heck can't your patient do a video visit, it's like they can't figure out the portal, and I'm supposed to click there, and I'm supposed to click there, and I'm supposed to click there, and if it's in a different language, it's very confusing. Very educated people like my mom and dad having trouble. And so to the degree that we make the user interface better, some of these equity issues could be improved because it may not be the technology aspect of there. The second thing I want to emphasize is that a lot of debate about video and phone calls. Why? Because that's what we're paying for. But portal messages, asynchronous visits, where you just ask the patient a question, are awfully convenient. And for our disadvantaged populations who often more are likely to work on an hourly basis, that's going to be a lot easier for them to access care. And so there's another example. If we want to address equity issues, we can do it. Are our portals in lots of languages? Typically not. Are we putting effort to get more people on portals? A lot of health systems are, but I think we can probably devote more resources to that also. So that was the thing, but that wasn't your question, Tim. Your question was really about the video versus the phone calls. It's a really good question. Unfortunately, I'm a researcher. I love numbers. I don't have numbers for you. I have stories. And so the stories is a phone call good enough? Matters. Checking in on a patient, probably okay. Behavioral health issue, maybe it's fine. You just have to talk to them. In some cases, the video is important. So it isn't a binary, always good or always bad. But I think that almost every clinician I speak with, and including myself, there's times where the video encounter is useful. And I think the common goal that we can have is how do we make sure that everybody has access to a video encounter, and what are the policy interventions, as I mentioned before, what are the things that a health system can do to try to really bridge that. The one other point that I want to emphasize is that while I think this is a very, very critical issue, I do want to emphasize that the wind is at our backs. Year over year, more and more Americans have access to these technologies. I showed you that below 100% of the poverty line among Medicare beneficiaries, only 50% had that technology access, but 50% did have that technology access. And, my own clinical experience is that unfortunately homeless patients, that's the only thing that they have, and they treasure that. And so because it is their link. So I want to recognize that as we move forward, our disadvantaged populations will most likely have the necessary technology to do that. So in that one component, the wind is at our backs.
Great. Wonder, before we go to QA, Megan, Courtney, Ativ, anything that came up for you during this conversation that you want to address before we open it up to the crowd? No? Great. All right, so going to Q&A, and please, everybody, feel free to put some more questions in the Q&A here, and I'll pick it from there. I'm looking, Janice, you wrote a number of things here. I'm trying to put context on who these questions are to exactly. So, and for everybody else, if you would put who the question you'd like to direct this to would be helpful, but I'll direct this to everybody then. We talked about patient data access. Are you currently exchanging data with payers so patients can get their clinical data via patient access APIs? Janice, who is that for?
Tim, I don't think she'll be able to answer live, but why don't we just open it up to our health system friends?
Yeah. So the question is, are you putting payers in your ecosystem as you think about being able to create more equity in reaching your patients? How are the payers working with you as you're all providers on this call?
And I think I just saw a comment that may have been partly aimed towards me. So because Henry Ford does have an insurance arm with the Health Alliance Plan, or HAP, as well as our clinical and medical side with the larger health system. So, it's interesting having an insurance partner within your organization as well, because we're not a closed network. That's not our only payer. We still have Medicaid, we still have Medicare, we still have other commercial payers like Blue Cross and the like. So we've definitely tried to align and partner with our payer partners as much as possible. And from my world in the virtual care space, making sure that we understand their payer policy around telehealth and virtual care, but then also give them active feedback as to where we are seeing gaps or we are seeing opportunities that they are not covering virtual and telehealth services. One example being the asynchronous that was just mentioned earlier, and how there's great opportunity to better have utilization and access to patients with the use of some of our asynchronous tools. So it is a two-way conversation, I feel like, with those payers from a feedback perspective. From a formal perspective, obviously we have the claims data and the claims that are going back and forth. But even with our own internal insurance partner, there are rules and barriers as to what data we're able to share and exchange both ways, both with our internal insurance partner and external. So we do need to make sure we're adhering to those as well.
I'll just add a very interesting, I think, data point that we have from our survey, that we asked clinicians whether they were connected to their state health information exchange, and then asked them whether they actually used it. And we had about 70% plus that said I am connected, and less than 50% who said they actually use it. So another workflow issue, but I think, one that is, we're not tackling at the rate that we need to.
I might just one of the things that came up in the Q&A and got me excited, Tim, so if I could just jump with that, with David's question regarding the portal messages and the communication. I made the argument that from an equity perspective, ability to answer a question via portal message, if it's a pretty straightforward issue, may be better for disadvantaged populations because of the time commitment and the flexibility. The question really came about reimbursement for that, and that actually raises a lot of other equity issues, which I think are complicated. In the days of old, 2 years ago, if you did a portal message, you didn't get paid for it. That was just a sort of a thing that a provider did, and that was part of normal care. Now there are codes, and most health plans and Medicare will cover e-visits. So there's some rules and regs about, like, has to be an acute issue and it can't be with, I won't go into all the details. But we have seen a huge surge in portal messages during the pandemic. And understandably, clinicians, health systems are frustrated by that because their clinicians are spending hours at night answering all those questions. This is good clinical care, but it takes a lot of time. And that care hasn't been reimbursed. That has created a push among chief financial officers saying, Dr. Peck, start billing those e-visits, because we need to get some of that unreimbursed time and translate it to reimbursable time, a very normal, natural thing to do. This is creating all sorts of issues. All of a sudden, a patient who sends a quick message to Dr. Peck saying, hey, I got this thing, it gets a bill for $70 because they have a high deductible health plan. You have a very angry patient. Cisco's also comes up with phone calls. Previously, I called Dr. Peck, it was free. Now I got to pay for it. And so the points that I want to emphasize is that this is good care, but the reimbursement system and translating previously free stuff to reimbursable stuff creates a couple of equity issues. $70 is a lot more money to a poor person than a rich person. They don't know when the heck they're going to get paid or when to get charged or not charged, because gosh darn confusing. The average doc doesn't know. How does the average patient know? And they also don't see value in it. 10 minutes of Dr. Peck's time in an in-person visit versus a phone call, from Dr. Peck's perspective, that's same amount of time. That patient doesn't think that. They're like, you mean I have to pay $70 for 10 minutes? That's ridiculous. And so these are issues that are really important for all Americans, but But I do want to emphasize from an equity perspective, the out-of-pocket costs and these unclear, are going to be much more obviously problematic. And I fear will deter patients from seeking care because they're like, gosh, I have no idea when I'm going to get charged or not. This thing is ridiculous. And they may stay home and not seek care. So just a couple of points there that I think are really important that were prompted by David's question. So something for us to ponder.
Seems very similar to the problem we had years ago, or still have, about observation status in hospitals, where you're put in this middle observation level of care because you were maybe not sick enough to go into the hospital, but not well enough to go home yet, and you got charged out of pocket for that for the most part, and those are big surprise bills. So how do, that's a really insightful piece of it. Where's the is this an education problem, or is this a payment problem? Do we need to change the payment way we pay itself, or do we need to just educate people that this is the way it's done?
Now you're getting to opinions, so this is me. So never put me in charge of the world, but I'll tell you what I would want to do. I mean, I think the long-term solution is pay people differently, right? Because you can't, you can pay for visits because it's like a thing you can get your head wrapped around. If you got portal messages, how much do you pay for that? Like $20, 25? I mean, it's a lot. It's not that much. And then what if you have an app and you're sending messages all the time? $10? It's just not worth it. Some have estimated that it costs a health system $20 in the whole claims processing system per bill. If you're getting reimbursed $20, you don't have to be a smart accountant to know that was a dumb idea, right? You spend $20 to get $20. And so at some point, that whole thing falls apart, and you do have to. So the growth of telehealth has brought to a head a problem that we have had for a long time, which is we need to pay on another way as opposed to the fee-for-service system. Now, in the short term, people have been saying that for a long time, so it's not a new idea, but it has accelerated that shift. Now, going to the short term, yes, you do need better communication. We need better systems to help understand, explain to patients, what are they going to be charged for? When are they not going to be charged? And maybe potentially different benefit designs when some of these things they don't have to pay out of pocket for.
All I wanted to add was definitely different ways of paying. However, value-based payment has a major equity problem. So that is not just, we've not solved it by moving into value-based payment, at least the way that it is structured right now. And we do not incentivize equity. We don't even measure or require measurement of equity very much in value-based payment. So lots of problems there too.
I think that's a great point. And so Laura asks a question related to that around, so stepping back, what we're saying here, value-based care, value-based payments, you need data to be able to make it work, right? With fee-for-service, you need some ICD-10 codes and some CPT codes, right? You don't need as much data to make that work to get the payment. And so value-based care, we talked about transmission of data being important in terms of integrations, in terms of workflows. But a lot of these populations, we're talking about how many of them aren't using the technology. So how do we know anything about that population if how we interact with them and collect data is by interacting with them through technology? It's a really interesting chicken or the egg problem. I'll open that up to anyone to take that from Laura.
So I'll jump on this a little bit, just more around kind of the chicken and the egg piece. I believe that we've seen the value of telehealth and how it can bring value to that healthcare industry. I mean, one of the graphs that Dr. Holtra shared was, certain percent of the population is using it. It's not everybody, but there's a population that's using it. And we should continue to monitor, but not remove the flexibilities and the ability to use these tools with the various populations and find ways to adapt the tools that we have to support some of those underserved populations, be it, like I mentioned, the use of the community paramedic or partnering with communities and things like that. Because if we really cut ourselves off from the ability to even be able to utilize the tools and get reimbursement or some comparable level of that for these services at all, it's going to cause us to fall off a cliff. And we're going to fall off a cliff back to the 1990s. And I don't know that any of us want to go back to the 1990s when it comes to the advancements that we have so far. So I think it's going to be a journey. It's going to be an evolution. I think working with social determinants of health, different partnerships and collaborations that we have to try to really reach that patient population that you're talking about, that they might not have access to that technology, so we can't collect the data the way we traditionally collect the data, but maybe is there case managers, is there social workers, is there other connections like community health workers that we have to be able to have more interactions with that patient population that can still glean us the data that's going to be helpful to feed the value-based models or some of the other models to keep this alive and supporting the value.
Megan, I see you nodding your head pretty vigorously to that. You want
Yes to community engagement. Yes to community health workers. Again, a reimbursement and payment problem. But we should be doing that. We should be getting there. And I think part of my comments about the equity problem with value-based payment, the clinicians who are participating or practices who are participating in those programs are less likely to be serving racial and ethnic minority populations, other underserved populations. And the way that we even, measure quality, are we stratifying by race and ethnicity? Again, a data problem, but I absolutely agree with Courtney that there are other ways that we can get the data that we need, and that should be compensated, or that should be valued in the way that our system pays for services.
Yeah, I even look at social determinants of health, and broadband and internet access was not originally one of the questions that was incorporated with that. Now it's becoming a very key and important piece, not just because of telehealth and virtual care, but also people are getting their groceries delivered. There's online learning. There's so much more that's happening now through the ability of somebody to have connection and connectivity to broadband. And so that's been a cultural evolution. And so this is kind of riding that wave as well.
Yeah, love that. So cutting the chicken out of the egg problem. So you're really investing in community outreach in traditional ways in order to define what the problems are and what we need to solve digitally. So a question from Huva, the platform that we're on here. What digital tools do exist besides, telemedicine component and the audio component? What digital tools exist right now that you might be using to collect that data? Not only having the personal outreach to people, but how are you getting your data, Ativ, for your studies, et cetera? Can you give us a little more insight into that?
Yeah, so one of the issues that we face is that the data come from primarily claims, so it is reimbursable stuff. So that's the one issue. And there is a problem that in some aspects of telehealth, that's just the tip of the iceberg. For example, with telestroke, we've done some work on, and of every 10 telestroke consultations, relatively few are submitted for reimbursements. We have to be very cognizant of that. Some also on portal messages, et cetera. So that's one issue that is an area. Now we do look at electronic health record data also there as another mechanism to do that, but that also just leaves a limited window on some of our patients, right? Because Henry Ford has the window in the world of when they interact with the Henry Ford system, and though the Henry Ford system probably encompasses most of their care, there are some patients who are getting care outside that, and you don't see those. So no data source is perfect from that perspective. I also would highlight maybe there are a couple of ones that I think are really important from an equity perspective that don't get the attention that no one is really, we do pay for it a little bit, but as e-consults. I'm not sure if any of you are familiar with e-consults, but these are electronic curbsides. And so a patient will, a primary care doc will type in a question saying, I got a patient in front of me, they got a rash, I'm not sure what to do, what do you think? And many large safety net systems, from San Francisco General to DHS in LA, Health and Hospitals in New York, and many other big safety net systems have made every single one of their consults e-consults. And it has led to substantial improvements in specialty access. This has really important equity perspective also. One, it improves specialty access, but two, I go back to the whole time thing, because it's a pain in the butt if you're busy in life to get to a specialist visit and figure out and if that could be addressed by your primary care doc through an e-consult, we've really helped improve access and improve care. It's not something, Tim, that's captured in data, but it's happening a lot out there. And I think it's a really important component when we think about how telehealth can address equity issues.
It's really interesting, especially the recent news, Oak Street, MA program and treating older adults at risk, acquired Rubicon MD. So I was getting it in my mind, which is an e-consult program. But
yeah, many of those direct medical, One Medical, Oak Street, and others use Rubicon's platform. And I think it's a really interesting way because they feel they can provide specialty care in a more efficient way because of that.
Right. Wonderful. So good full circle right there. So Catherine, you'd like to wrap us up here?
Yes. Thanks, Tim, and thanks to the whole panel. That was fantastic. I was just coming on quickly as this is the last panel of the day. So I just wanted to say again, as we started off the day, a thank you to our supporters, which are here, which we could not put on this event without. So thank you to all of the companies here on the screen. And then I also just wanted to say that this is only day one of our 2-day conference. We have a lot of panels tomorrow, a lot of which are continuing the conversations that we've started today, including on health data equity issues, some more discussions around building tools for diverse, underserved and vulnerable populations. So check out the agenda through Whova if you haven't already. Add sessions to your agenda, and we will see you all tomorrow. Thank you so much. Have a great rest of your evening.
Thanks, Catherine. Thanks for inviting us.